at our family destruction center over there. And the woman that would handle the visit supposedly got a flat tire. And, you know, these things happen in life, but when you're like that close that you can actually touch something and then it falls apart in front of you, that's been my last 3.5 years. And that's been the way it's been with any county resource or anything through our courts. This is very, very frustrating, and I brought it up about the grant that's going on with our court right now. We only allow 1 hour a week for people that can't afford to see their children. Now remember, when this first started, it was only once a month for an hour. You know, I'm going to take what I can get, but imagine a child going into that courthouse there and going up to that 5th floor and going through those scary doors. I mean, the kid can't even open the door. I mean, they weigh about 1,000 pounds each. Guards with guns. I mean, I just don't think it's the proper environment. We provide visitation for foster children, which I understand is important, but we have a nice location down the street. Seneca, I believe, is what it is. Why can't people like myself ride the coattails of that program and be able to see our kids in a safe, non-confrontational environment? I just don't get it. When are you guys going to start kind of figuring this stuff out? I got stuck in a donut right now that I'm unable to get out of, and we still don't see any success stories. Where are all these people that got off of drugs, that got off of meth, that did the right thing? Because there is no path. It doesn't exist. And I think in Santa Clara County, we missed the mark on tons of stuff. And the reentry center meeting, I hope you guys maybe chime into that one. The last meeting, well, actually the last 3 years of meetings, we continue to talk about booze, okay? We continue to talk about a sobering station over there when we have a meth problem. So what's the point of that over there right now? They're on meth, they're not on booze. And if you people woke up, you'd start understanding that. We could start pulling the meth addicts off the street. So that thing over there is a failure. And I'm wondering why we're excessively billing the mentally ill and homeless for services where you guys aren't doing a very good job at all. It's getting worse and worse, but you're unable to pull these people off the streets. You're too scared to even go talk to them. I mean, when somebody's right across from City Hall and you call behavioral health and you say, this woman's got a major problem, she's butt naked, she's smoking meth, she doesn't know where she's at, she's screaming and yelling, but behavioral health is too scared to show up. They want police to show up there. But law enforcement in San Jose is fed up of all these calls of going out and behavioral health not being there. Right hand's not talking to the left hand, and it just gets worse and worse and worse. Please show me one success story. I call you out on that. Show me one. Because I'm not a success story, because none of this stuff worked.
Thank you very much. Let me just confirm with the clerk, we do not have any other items under public comment. Any other speakers? We do not. Thank you very much. That takes us to item number 3, which is to approve the consent calendar and changes to the committee agenda, if any. Supervisor Ellenberg, I note that items 8 through 13 are identified as consent calendar possibilities, and if you're amenable, I would gratefully entertain a motion to approve the consent calendar as contained in our published agenda.
So moved.
We have that motion. We have no cards on this item for members of the public. We do not. So, without objection and hearing none, consent calendar is approved. Thank you very much. That takes us to item number 4, which is to consider recommendations relating to medical staff and allied health professionals at Santa Clara Valley Medical Center, O'Connor Hospital, and St. Louis Regional Hospital. Welcome.
Good morning. Thank you. My name is Yvonne Karanis, and I am president of the Enterprise Medical Staff. I'm here to present the credentials report and answer any questions if you have them.
Thank you. We do have the materials contained again in our published agenda. I'm looking at packet page 4 and subsequent pages. Supervisor Ellenberg, any questions? Or if not, a motion to simply accept and approve the recommendations relating to medical staff and allied health professionals?
So moved.
Checking that we have no cards on this item. We do not. Then we'll say thank you for being here. And without objection and hearing none, so ordered.
Thank you.
They're considered, they're approved. We're good. Thanks. Takes us to item number 5, which is to receive the report from the Santa Clara Valley Medical Center relating to adult and adolescent sexual assault forensic exam program expansion. I do have one card from a member of the public on this so far, and that's from Mr. Largent. If there are others here who wish to speak to that item, they should go ahead and turn in a yellow card. I believe the yellow cards are available in the back of the room and at the front as well. Okay. Mr. Largent, would you like to speak before the presentation? Sure, come on up.
Thank you. Reverend New York, Dave, thank you. A friend of mine, well, actually several of them that I've kind of met down here, that went through the process with Valley Medical. They were either sexually assaulted or raped. Very, very sad situation. When they told me about the different process for the exams, they always talk about they were sent to a trailer. So I know we're doing remodeling over at Valley Medical, but is the sexual assault unit right now a double-wide trailer here in Santa Clara County? I'm not sure if that's the case, but that's what these ladies are telling me. And maybe that's positioned right back there near that psych ward. I know we're going to eventually tear that thing down. Can we maybe run the lawnmower, maybe replace some of the light bulbs over there, maybe help people be able to navigate that place back there? It's very confusing back there. I spent half a day there before they had to kind of let me loose. Is this the case with that sexual assault unit? I know we're rolling things out and doing things, but it takes way too long. And the dog and pony shows that we put on in our county about sexual assault, this whole system is a failure. If you guys showed up to the domestic violence committees, if you showed up to the Office of Women's Policy meetings, we are failing women in our county. We're not staffing these meetings properly. We're just dropping the ball. And stuff that comes out on the news is 3 or 4 months late. We already knew that rapes were up in San Jose 3 months ago when they did a presentation at the Office of Women's Policy meeting, but the county just comes in late, and then we get councilmen and women that start chiming in, and they're just in the past. I don't know why people don't wake up and start showing up to this stuff. Thank you.
Let me just confirm with the clerk, we have no other cards, to the best of our knowledge? No? All right, then. Thank you. We'll welcome staff to the table and ask you to share your name and your title just for the record, and please begin the presentation.
Good morning, Supervisor Simiti and Supervisor Ellenberg. My name is Andrea Brolini. I'm the Director of Nursing for Critical Care, and beside me is Kim Walker. She's our nurse coordinator for our SAFE program. Kim and I are here this morning to provide you an update on the SAFE program and our expansion into South and North County, as well as some training updates. We have been working very hard over the last couple of months in collaboration with Stanford University Medical Center in regards to trying to locate some space there in their emergency department to perform our SAFE exams. We have come to a pretty good agreement with some new space in their new emergency department that's going to be open towards the end of the year. And they have agreed to provide us some space that we can store our things and provide exams when the patients present to the emergency department. That is going to be referred to as our North County Center. Kim has been working with the Stanford hospital leadership over there to operationalize, work through protocols, and start planning for the training for both the physicians and the nursing staff at Stanford so that they are prepared and ready to receive these patients and are able to do so in an appropriate manner. So we're very excited about that. We're looking towards the end of 2019 for the rollout of that program and the North County Center. The South County Center, we already have dedicated exam room space at the Valley Health Center in Gilroy. We are exploring options to move that over to St. Louis now that we have a good collaboration with St. Louis, just because it makes it easier to take patients straight to an emergency department and have all the services readily available. So we have reached out to nursing leadership at St. Louis in order to see if we can find some space down there. We do have some current recruitment efforts going on, and Kim is also hoping to reactivate the South County Center by the end of 2019. The Center at Valley Medical Center is going to continue to be our central site for forensic medical exams performed by our SAFE nurses. The business office is located there, Kim is there, and it's a nice clinic and has been in that place, gosh, for how many years, Kim, have we been in that one spot? 32 years we've been there. So it'll be our main central hub for the SAFE program. Also want to update you on Santa Cruz County. We have a partnership with them, as you know. Right now, the patients from Santa Cruz County are coming over the hill to receive their SAFE exams by our nurses due to their staffing issues. And Kim has been working with them very closely on reactivating the clinic in Santa Cruz County and we would provide the nursing staff over the hill so that the patients don't have to come all the way over 17 in order to get their safe exam. Staffing, again, thank you for the positions that you approved for our SAFE program expansion. We have 5 positions that we're recruiting for. 3 of the 5 have been filled already on a provisional basis. As soon as we can get them filled permanently, we will switch them over to permanent status. Filling these 5 positions will be very important to ensure that we have a seamless transition and expansion towards the end of the year, including filling our nurse manager position, 2 nurse coordinator positions who will also take call during the daytime business hours, a medical unit clerk, and really importantly, a staff developer. As Kim's going to talk about, the training aspect for this program is pretty significant, and we have been really working with some of the outlying agencies to bring more training to Santa Clara County and also to use that for a recruitment tool.
So good morning. I am Kim Walker. I am the program coordinator for the Adult Adolescent SAFE program. The positions that Andrew was just talking about are also going to allow the SAFE program to develop a training protocol that makes us less dependent on outside agencies with limited course offerings. The first thing we're doing is we're working with the California Clinic Forensic Medical Training Center.
Excuse me, Ms. Walker. That was extraordinarily tactful on your part.
Thank you. We will be working with the training center to bring a 3rd training. They only offer 2 in a year, but we're going to be offering a 3rd one in October, and we confirmed that 2 days ago it will be in San Jose the last week of October. We are also partnering with UCSF School of Nursing. A partnership with them will allow the SAFE program to collaborate in the creation of a standardized curriculum for training our examiners. This curriculum will focus on trauma-informed approach to care, including interviewing techniques that utilizes the simulation training with live actors. The benefit to this is that any of our trainees that go through this program will not only be seen free of charge, but they also will then have their registration to the 40-hour class paid for, which is a huge benefit. It's about $500. We are working to offer the UCSF training to our trainees in the fall of this year. We're also working with the School of Nursing at San Jose State University for a hands-on skills training with simulated exams. We had an initial training with them in May of 2019, which was very successful. The feedback has been quite good. We feel that it will shorten the training time for our examiners. And we are planning a 2nd training in the fall for our examinees. The goal of these 3 classes is to reduce the time it takes to train a new examiner to about 2 months or less. Right now, it's almost 10 months to onboard a new examiner, so it will reduce the training time significantly. Once we have everybody trained, though, we still need to make sure that there's coverage in place to respond to these additional locations. And the board has been kind enough to approve funds that will provide and allow us additional call coverage. What we want to do is have a 2nd examiner on call for weekend nights and evenings, and a 3rd examiner on call, 2nd examiner on weekday nights and evenings, and a 3rd examiner for weekend nights and evenings, which is when our kind of curve of most of the exams are occurring. We also will use the core staff to streamline our training and our precepting to make sure that the waves of trainees are onboarded very smoothly and systematically, and there's no kind of issues with response to patients as we increase our service. Another thing I want to tell you about is the sexual assault protocol. This was developed by the County Sexual Assault Response Team. This committee is defined in the Penal Code 13898. It is consistent of law enforcement, the forensic exam team, crime lab, the DA's office, and the sexual assault advocates. We have come together to kind of create, outline the partner response to sexual assault in the county. This protocol will serve as a memorandum of understanding among the agencies. Currently, we are completing the review and acquiring signatures. The last approval that we are obtaining is from the chiefs, and we're on their agenda for July 11th. So we plan to have this signed and ready to go by the end of July. We completed a Train the Trainer event in March on this protocol. Going forward, the work of the SART committee will inform any future versions of the protocol. We want to review trends and data to identify gaps in response and care of sexual assault victims that we see here in the county. We also want to identify any additional agencies to participate and strengthen the multidisciplinary coordination. The first group that we have identified as being necessary to this process is EMS, and as of yesterday, they are part of our SART committee, and a very strong partner, actually, because the initial contact with sexual assault victims is so critical to the outcome of their care and how they do following sexual assault. So to have EMS on board is going to be a huge piece of benefiting the committee. We also want to make sure that we have an annual report to the Board of Supervisors based on the activities and the findings of the committee. So that's it. Any questions?
Thank you very much. Let me first confirm with the clerk we have no other speaker cards on this item. We do not. Supervisor Ellenberg, I see your light is on.
Thank you. I really appreciate hearing this report, and as I'm guessing you all know, I joined at the last Board of Supervisors meeting, I joined Supervisor Chavez in a joint referral concerning more expedited funding options for YWCA and Community Solutions for sexual assault counseling and advocacy services. And as part of that referral, I requested that the report back from administration include the status update on the SAFE program expansion and staffing efforts in order to really make sure that we are providing comprehensive support and exam services. So I just really want to first appreciate your work. Can you give me a sense of the numbers? How many participants does the SAFE, SANE training program have in each cohort of the nurses program, past, present, and what you're anticipating?
The number in the cohort will depend on the number of recruits that we have for each iteration. The 40-hour class holds 42, so we're hoping to fill that in October and then have that wave of nurses go through each of the UCSF and the San Jose State training as well.
And do you expect that to be a tough number to get to, or will people really be eager for this training?
I think that we could probably get to that number. Certainly there will be other local agencies that will want to send people as well. The issue, too, is that even though we have that number going through, they don't all stay. So you could take a percentage of that number as who you might have in the final group that would be part of our team.
And do you have a best guess or past experience about what percentage makes it through?
I would probably say 60% make it through.
Interesting. And you also mentioned, Kim, the sexual assault protocol report. I haven't seen that. Can we get a copy of it? Off agenda is fine. Or does it need to be fully signed before it's distributed?
Protocol?
Yes.
Yes, we can get you a copy of that.
Great. Thank you very much. That's all I have.
Thank you. I don't have a lot in the way of questions, largely because the report and the PowerPoint that came with it are very thorough, and also because we've had a chance to talk outside committee. I do just want to make a couple of notes. One is I'm pleased to hear about the progress in the North County. Obviously, that's actually the sort of the beginnings of my involvement with this issue. Having said that, lest anyone think I'm just parochial, I really am pleased about the partnership with Santa Cruz County. This is a place that I know because I've represented it previously in the state legislature. I did not realize, candidly, that folks who had been subject to sexual assault in Santa Cruz County were essentially obliged to come over the hill in order to receive an exam at VMC, which is, not an acceptable circumstance. So I'm particularly pleased with that partnership as well, and I'm glad we're thinking regionally, and just sort of want to underscore that in the conversation. To grossly oversimplify a very complicated set of challenges, it seems to me we need to hire enough people, get them properly trained, and have a place for them to do the work. That's the 1, 2, 3 of it. And so when I'm asking myself how we doing and are we making progress, I'm listening for how we doing on those 1, 2, 3 things. And it sounds like we're making real progress on all 3 fronts. So thank you for that. I was interested, and I don't know if it's easy for Ms. Carter to get us back on the protocol screen, But I wonder if you could talk a little bit about why this protocol is important, because I think it's easy to think of that as sort of a bureaucratic, legalistic thing that isn't sort of directly related to the 1, 2, 3 of do we have the people, are they properly trained, and do they have a place to do the work? But I thought it was helpful that you underlined a couple of the reasons why it's important. But if you could just talk a little bit more about why the protocol is important, and perhaps most importantly, how will it impact the experience of the people who are drawn into this system? How will it help ensure that we better serve? Waiting times clearly seems to be one of the key remaining challenges, and it sounds like the protocol might be a basis for making progress there. Yes? No?
Yes.
Thanks.
The protocol hasn't existed previously. This is the first one. And it's a little bit different than the law enforcement protocols in that it is multidisciplinary. So it crosses city and county agencies, and it's basically, like I said, an MOU of the agencies on how to best respond to sexual assault. There are issues with processes that don't necessarily perfectly align, and this is an opportunity for us as agencies to work together to smooth out any of those kind of competing issues. Also, if there's an action on one agency, it might have a negative ripple effect that they are unintended and unknown that we can talk about so that we can work those processes out as well. The goal is really to have the patient, a victim of sexual assault, be able to enter the system at any point and have us all know what the process is so we can get them smoothly through the resources and the agencies they need to see in order to get their care.
Ms. Walker, thank you. You mentioned issues across boundaries. Could you give us an example of one or two?
It might be the way, making sure that sexual assault advocates are present, making sure that there's the new patient's rights information that we need to give out. So the SART committee created the trifold information. It needs to either be provided by law enforcement or it needs to be provided by the medical provider. We came together and created one so that it all says the same thing and all the agencies use it across the county.
We've worked together enough now, you know I'm always trying to oversimplify these very complex things. So is the protocol about, insignificant part about then making sure that people who are part of the process know what they have to do so that it gets done? Is it about clarity and agreement on here's what everybody's role and responsibility is?
In part, yes. That definitely is part of it. But some of it, looking at the processes for, trying to find a simple example, there are exams that we can do under the Violence Against Women Act. We call them non-investigative reports. Patient can come in, they can have a full medical forensic exam and not report to law enforcement. This has been a huge process that we've all needed to get together and talk about so that we know how to handle evidence and make sure the patients are properly provided their rights without having law enforcement be part of that process. So that's an ongoing conversation with this committee to make sure we all know what's expected of each other, both legally and within this county.
Thank you. Shifting to a different question, just so I make sure I understand what's entailed in the process that you're going through to get us where we want to be in terms of service. You mentioned a little bit the precepting process. I think I know what the word means. I went online and spent a little time there. But could you tell us what it means and really what it entails? What is it's a term of art that you use in your world that is not regularly used in the rest of mine. Let's put it that way.
So as far as the precepting goes, it's one of our examiners on our team that's taking a new trainee through our process. Outside of classroom, outside of UCSF or San Jose State, we have to walk through our emergency department, our processes, our protocols, and so we precept them through that process. So it's in our program on site.
Does that just mean train?
Yes.
Is there something else about it that I should understand?
It's just the term I think that we use when nurses train other nurses.
Got it. I want to make sure. When I first started on this committee and people talked about people presenting, and I quickly figured out that meant showing up. But it's just a different term of art than I'm used to using in the world that I use. Or does it mean dramatically more than that, and I'm about to get schooled? No? Okay, good. Supervisor Ellenberg, anything else on this issue? Before I hand it back to you, I do just want to underscore, it sounds like waiting times is still a challenge that we're going to have to confront, and I should just underscore, I, along with everybody else, I think, thinks it's a serious issue and needs to be sort of part of our thoughtful effort to get to a better place here. Thank you. Back to you, Supervisor, if anything else. All right. Then last question, just to put, as my colleague Supervisor Chavez would say, a pin in it. So North County, date that the services will be ready and available, no later than, if it seems like I'm trying to.
February 1st, would that be acceptable?
2019 would be even better, but I got February 1st, and I know that you're working with folks there to try and make sure it happens on a timely basis. Thank you. It's helpful to know that we have a real and meaningful target. Then, without objection, Supervisor Ellenberg, motion to receive the report. Motion by Ellenberg, second by Simidian. Without objection, unanimously received, and thank you again for the work. Much appreciated. Takes us to item number 6, which is the hospital integration report. And
Thank you, President Simidian, Supervisor Ellenberg. There, of course, in your package is a written update. I do want to update you on a couple key items, one of which you are aware of. On August 17th, we will have the go live of our EHR, otherwise known as HealthLink. There's a lot of preparation and work underway, including the installation of the information technology infrastructure. We will, in the month of July, begin end-user training. We are estimating that 3,000 individuals will go through that training effort, including approximately 600 physicians. So we are looking forward, obviously, to that date. And at this point in time, we just recently had our 60-day go-live readiness assessment, and we are in a watch status. So things are looking positive in terms of our readiness to go live on the 17th. And I do want to acknowledge again, and I think this is really important, the work of the staff at the respective hospitals, as well as the IT team, TSS. The other item that I'd like to bring to your attention is that we continue to equip the hospitals in terms of bringing in not only the technology, but the equipment. This week, actually, we have deliveries of new beds going into both facilities, 154 at O'Connor and 40 at St. Louis Hospital. So that is a very significant sign for the staff that we are making progress. And I think over the next couple months, things will really start to move relative to the installation of equipment and the provision of that equipment to staff. We have also been focused, obviously, on the stabilizing of the workforce at the two facilities. This is quite the undertaking. As you well know, movement of the staff from provisional status to permanency is a major priority of ESA and hospital leadership. I will turn to Dave Manson, who's here to respond to any specific questions that you may have on the employment. And then after that, we do have an update on the financial status of the two hospitals, if you would like, Supervisor.
Thank you. Supervisor Ellenberg.
Thank you. I really appreciate all of the continued hard work that is going into this integration. I do have a couple of questions that I think are best directed to ESA. I appreciate that these metrics have been added to the report, but there are a few places where I'd like to get a little bit more information. Is there a projected timeline to complete interviews and make offers for the nursing positions that have been posted?
Supervisor Ellenberg and Supervisor Simidian, Dave Manson, Employee Services Agency. Yes, actually there are several lists already out to the two hospitals for specific nursing positions. They are interviewing right now, and the rest of the list will go out the beginning of July, and so they will have those lists to interview. I guess the time frame would be once the lists are posted and they go through the interviews.
I'm sorry to interrupt. I have a term of art question now.
Oh.
Putting the list out, does that mean positions, or does that mean, does that mean availability or job offers or filled positions?
Yeah, all of the employees have to come off of a open competitive list, a recruitment list. Those lists, like I mentioned, there are some that are out now. They're interviewing for those clinical nurses. There are other lists that are coming out for the rest of the clinical nurse positions. Those will be out in July. I would think that going through the interview process and getting them the offers would be probably between the end of July and the end of August.
So you expect to be completed by the end of August?
For the clinical nurses,
Okay.
hopefully.
I hope
Excuse
so
me,
too.
if I can just clarify. When you, I appreciate the fact that you were very specific about for the clinical nurses. Does that mean then there's somebody for whom you won't be completed, and who is that? If I may steal a piece of your question, please. Thank you.
There are 116 classifications that all of the provisional employees are in. We prioritize the clinical nurses specifically to get those through first. So throughout probably the next 4 months, we'll be doing recruitments for all the classifications. I highlight the clinical nurses because those are the ones that we're on right now, and those are the ones that will probably be finished first.
Sure. I see Dr. Smith leaning in, so I'm going to turn to him, but not before teeing it up for him, I hope, by saying that could lead someone who was a glass half empty kind of person to say, it sounds like that means we have 115 of the 116 classifications that are not yet, that won't then be completed. So I'm curious to hear what your take on this subject is.
Well, two things. Can I clarify
Please.
regarding
Please.
Supervisor Ellenberg's prior question? The process for hiring under the merit system really requires sort of 3 reviews. So the first review is an application and a review by a specialist to make sure that the minimum qualifications for the position are expressed in the application so that an individual meets those minimum qualifications. Then next there's the so-called subject matter examination or review, which is a separate review, different for every classification in the county, but essentially is an evaluation that's used to rank the applicants 1 to whatever, in this case 1 to 5,000, and that is the list. So those are the qualified applicants. Then the hiring manager, who is the appointing authority, which is not the department head, but the individual manager in the particular unit, requests names from the list and gets them sequentially 1 to 7 at a time, and does interviews. That's the third review, and then the hiring decision is made. So it is an intense process. And then to answer Supervisor Simitian's question, we prioritize the clinical, filling the clinical positions first because those are the ones that are most important to actual patient care. And that's not to decrease anybody else's importance, but the other classifications have smaller numbers of applicants and smaller numbers of vacant positions, and everybody will be completed within all the applications, and hiring processes will be completed within the provisional period, but it might mean that they're provisional for a longer period of time. I hope that answered the questions.
Well, let me ask, just drill down a little bit more, if I may, and thank you again, Supervisor Ellenberg. So did I hear correctly there are 116 classifications?
That's correct.
Okay, so, and we've prioritized the clinical nurses for reasons that have been explained. And so let me just try it this way. How many people are in this provisional category or status in the clinical nurses category? and how many in all others? And I'm not asking for a precise number. I'm trying to get a rough order of magnitude, both of how many are in one category and then all the others. And I'm also trying to get some sense of a relationship between those two numbers.
Certainly, Supervisor. There's roughly 1,200 employees in the provisional status, and about 600 of those roughly are nurses.
Or clinical nurses who are, okay. And those, again, you said earlier in response to Supervisor Ellenberg's inquiry, we think we'll have wrapped up by August?
We'll have the offer. We should have all the list out and the offers and the interviews going by the end of August, and the offers can be made right after that.
And this number, you were making a comment about 115 of the 116 not addressed. The clinical nurses, or the people that, the lists that are out right now are not just for one code, right? It's about 25. 25 of the codes?
That's
that
correct.
correct?
There's actually 216 applications that were referred. So with the clinical nurses, there's also competencies with each list. So while we're talking clinical nurse 1, 2, and 3 as a classification, within those classifications there are competencies such as the emergency room or labor and delivery. So,
well, with the forbearance of my colleague here, I want to sort of make one more point or ask one more question, then hand it back to her, which is, so, and maybe Mr. Lorenz wants to get into the act as well or not, but so if we're talking about 1,200 people, and we've got maybe 600 clinical nurses who we're hoping to be able to address by the end of August, does that mean we've still got another 600 folks who are out there who are still in provisional status?
that's correct.
Yeah. And, you know, hearing from some of our employees, I mean, Supervisor Ellenberg, before you joined the board and when we were first contemplating the purchase of the hospitals, you know, the phrase I used was that I thought this was going to be a very big lift, because while there was clearly excitement and enthusiasm and determination in the organization, I thought it was important at the time not to minimize just what an undertaking this was. And I think we're now seeing that play out on a daily basis. And as I've said before, I think, you know, when you enter into a $250 million enterprise that involves 1,200 employees, candidly, I'm not surprised that we haven't got it all sorted out 4 months later. That being said, you know, for each of these individuals who remains in provisional status, I can understand the anxiety that they feel, because, as I've said before, for them it's 100%. It's like it's their life, their work, their day-to-day job. And, you know, if you've still got 600 folks in the system after 6 months, who, or some significant number, whatever it turns out to be, who are provisional, you can understand that creates anxiety. And please be clear, I'm not laying this on your shoulders, but you can understand that creates anxiety, and that anxiety can't be good for morale, and morale ultimately has some impact on quality of care. So I just want to underscore the interest and attention that my colleague, Supervisor Ellenberg, is indicating on this issue of provisionals. I know, as Dr. Smith has detailed, how daunting a task it is, but I do think pretty much every organization runs best when people feel like they know that they are a part of the organization and their status is not unsettled in some way. So, Supervisor Ellenberg, thank you very much.
Thank you. The report also notes that ESA has resolved more than 530 staff concerns. I want to say maybe congratulations that you've resolved them, or a concern that we had that many. I really don't have a context for that, but I'm wondering if you can comment on how many of those issues were related to initial offers.
I don't have a specific number, Supervisor. I can surmise that it was probably about 60 to 70%.
And are there still issues that are pending that have not been resolved?
There are still some issues that are pending that have not been resolved. Yes.
So if I would like in the next report for a breakout of the issues that were resolved and which are still pending by general area, obviously not people-specific complaints, but I'm curious to know what the trends are, and that might help us also look at the bigger picture if we see what those complaints look like.
We can do that, Supervisor.
Thank you. And I want to note also that at the May meeting, I had asked for administration to provide an off-agenda report within 4 weeks relating to employees who requested relief or support in emergency situations who couldn't afford unpaid leave. And my concern was particularly for the new nurses that came over that lost their accrual of that sort of time. And I haven't received that yet. So I want to flag that I am definitely still waiting for it.
Supervisor Ellenberg, I will follow up, but I believe that report has been prepared and has been issued, but I will double check on that with
And I
ESA.
will double check as well on my end, but I don't recall seeing it. So
All right,
let's
I will
connect
follow up
afterward.
for you, Supervisor.
Okay, thank you very much.
Thank you. A couple of other questions, if I may. Could you, or Mr. Lorenz, share a little bit about the use of what are known as travelers and how that affects the operation? And I've gotten some concern expressed from our employees about the number of travelers and what their role in the organization is. I don't have a reaction to it yet. That's why I'm asking the question.
Very, very good question. And this is actually one of the other reasons why the clinical nurse series have been prioritized in terms of recruitment. At O'Connor Hospital, we have probably around 120 traveler nurses on staff. I think that number has somewhat gone up over the past several weeks.
Excuse me, Mr. Lorenz, it's gone up because we have more patients, because we have not enough nurses, just trying to get a sense for the causal.
We continue to see a turnover of nursing staff in some departments more than others. So to a large degree, when we started out this process, a lot of the use of travelers were prior to the actual March 1st acquisition, but that number has gone up. And so our goal is to immediately, particularly in those units that we have a high percentage of travelers, to focus on those areas, so the emergency department, ICU, so forth. So we are looking to prioritize in those departments where we are heavily reliant on travelers.
Great. And I notice we have
Hi, I'm Pat Ryan. I'm the hospital executive for O'Connor Hospital, and I just wanted to come and support Paul. Our numbers increased for several reasons, the ones that Paul had talked about, but also we're currently preparing for HealthLink Epic install. And in order to have our staff trained on Epic, you have to take them off the floor and give them time to train to absorb it so they're ready to go. So we have a bolus right now of an increase in order to give them that opportunity and train. It's never been our ideal to have traveler anything. However, we've had turnover. We expected it with the transition, and we have actually decent compliments from our physicians on our travelers and meetings that I've been at yesterday, even in our quality meeting, that they are pleased with the caliber of travelers we have, but also anxious for us to recruit our own staff and move forward.
Got it. Thank you. If I could ask, what percentage of the staff in the acquired hospitals and facilities ends up taking a pay cut, and why? Is it?
Supervisor, I don't have that information right on hand. We can get back to you on that. The numbers is as far as the percentage. The why is obviously we were putting all these individuals into the classifications that the county already has. And those classifications, as you know, already have set salary ranges. And so it may not have been what they were making under their previous organization. When they come to the county, based upon the duties, they go into that specific classification, and they're subject to the salary range that we already have established here in the county.
So is this more a function of classification than of wage levels compared or contrasted with what Verity was paying? Do you understand? I'm sorry, am I being clear with the question?
I think yes, it has more to do with the classification. Our classifications each have a set salary range. And so as the individuals are put into that classification, they're subject to that salary range that we have.
Okay. I appreciated the information, Mr. Lorenz, about sort of where we are in terms of electronic health records and all of that. Wouldn't be a Health and Hospital Committee meeting if I didn't say, let's please be mindful of privacy and security. So now it's been said again. Do I note that there are some variances in the St. Louis budget in particular?
So a couple comments, and I believe this is your question. So you see variances in volume and utilization at each of the two hospitals. Yeah. At St. Louis, you see actually an increase in utilization of the emergency department, but also in patient days. So that's good news. And if you look at the two different markets for which the hospitals serve.
I'm sorry, I'm smiling because only a hospital administrator could say, good news, we have more people in the hospital. But I know what you meant. But as you are sharing this explanation, again, I'm curious about the causes. Thank you.
Okay. Actually, I see John Henley just stepped up to the mic. Maybe John, would you like to give your perspective on that as well?
Thanks, Dave. The increases are largely due to the acknowledgement that there's a county facility now in South County. So in the past, we had many people who were comfortable engaging Valley Medical Center only for their services because that was the county facility they were comfortable and familiar with. With the acquisition, there's now an understanding that this is an extension of what I already know. And so there's a willingness and comfort to come in for people who were traveling 30 miles to come up to San Jose for care. So it's a positive.
Got it. And last question for me, at least for the moment, is, and I think I'll look to Mr. Lorenz on this one. You know, we've talked previously about how long this transition would take, that in many respects it was at least a 3 to 5 year process actually before we feel like we're a fully integrated organization and the cultures have blended and we've all learned from one another and so on and so forth. But in terms of just these sort of administrative matters, and I don't mean to diminish them because they're pretty big administrative matters, working our way through this provisionals process, making sure everybody's properly coded and categorized, getting the electronic health records, making sure that the administrative systems are compatible as between and among the hospitals. March 1st, I believe, will be our anniversary date next year, yes?
Yes.
Should we be done with the administrative stuff by then? I'm trying to ask myself, you know, I'm looking for that light at the end of the tunnel. When are we going to say, no, we really should have these administrative matters sorted out and have the place running pretty well in terms of integrating the systems?
Supervisor, you've mentioned a couple of the key administrative items that should be resolved and actually will be resolved by March 1st. One is the implementation of HealthLink, which both affects the clinical documentation and management of patient care, but also the revenue cycle. And John Cookingham would speak to the importance of that. The second item is respect to ESA and the work around the transition of staff to permanency. And as Dr. Smith has said, we have 12 months for them to remain in the provisional status, for which time they have to move to permanent status. The third issue is really around all the contractual work that is underway, both in terms of physician-provider contracting, but also vendor service contracting. And much of that we expect to be also resolved by March 1st. And all three of those are major undertakings, and in your words, a heavy lift. But we do have all hands on deck. Ongoing, it really is all about strategically how we move forward as a system, and that's an ongoing effort and discussion.
Got it. Thank you. All right. Thank you very much. Supervisor Ellenberg, anything else on this item? Staff, anything else you'd like to present since you're here, and thank you for being here?
Thank you, Supervisor.
Good. All right. Well, then I'll ask Supervisor Ellenberg for a motion to receive the report. We have that motion without objection and hearing none. We'll say approved unanimously. Thank you very much. That takes us to item number 7, which is the director's report. There are a number of components there, but we do have a card from one member of the public, Mr. Largent, who would like to speak on some portion of item 7. So why don't we call you up, Mr. Largent? And let me confirm with the clerk that's the only card we have on this item. It is. Thank you.
Thank you, Scott Largent. I always like to come in here and comment on the behavioral health end of things. I looked over, a friend of mine sent me some, not necessarily like internal information, but just some stuff about your guys' budget. And $528 million goes into behavioral health. So maybe I didn't realize it was that much money. It's a lot of money right there. So I was, did we drop the ball on this reentry center over there? Did we drop the ball with the booze thing? I am frustrated with government when I come in and explain that I'm an unsatisfied customer and that things did not work out, but nobody wants to fix it. Nobody wants to say, hey, this is what didn't work out for a member of the public that dealt with all this stuff. And when I ran an electronics business, I made sure my customers were happy. I asked them what was going on. I stayed in contact with them. When I had a salesperson that was having a conflict with a customer, I immediately pulled that account. I immediately got in there, did the damage control, figured out what we did wrong and what we could do to better serve that customer. We don't do that in Santa Clara County at all. And I'm an unsatisfied customer. I don't think this stuff works. I'll continue to come in here and say it doesn't work. But if we watch the reentry center meetings, we'll know that our county is completely doing things the opposite of what we need right now. That's like, all the different cans of Raid that they have, stuff for ants, stuff for wasps, all these other different things. It's like our reentry center over there. We're using the wrong chemical to treat this right now. We're going the wrong direction right now. We need meth addicts over there for detox for more than a week or 2 weeks. It's not booze. Booze is not the problem. If we have one person there a day, we should have 20 in there a day and detoxing them. Thank you.
All right. Thank you very much. Again, confirming no other speakers on this item. And ordinarily, I would turn to Mr. Santiago for the director's report. But instead, I will turn to
Mr. Lorenz.
All right.
Thank you, Supervisor. So just a couple comments. Obviously, Renee Santiago is on some much well-deserved time away from the office. There are 2 items that I would like to just highlight in this report, and it does have to do with coverage expansion. As you well know, the governor's budget included the expansion of Medi-Cal eligibility for the remaining pocket of young adults, ages 19 through 25. So that's obviously very important to this community. The other is, of course, the Covered California subsidies, where additional funds will be made available given the premium costs of the program to allow for additional subsidy for individuals up to 600% of federal poverty level. So obviously in our economy, that is significant. We're looking at an average subsidy of $100 per month to further encourage people to enroll in the program. With that being said, I'd be happy to answer any questions regarding this report.
Thank you.
I should jump in here.
Please jump away.
Say, regarding those 2 issues, the board has expressed, or the committee has expressed interest in getting much more detail about that. And as you're well aware, the passage of the budget is just that, the passage of the budget, but regulations and procedures are the implementation of the programs, and we believe that we should have enough clarity about the regulations and implementations to give the committee a more detailed explanation of the effect of those expansions of Covered California and Medi-Cal during the August meeting of the committee, and that's our intention if it pleases the committee.
Thank you. And thank you, Dr. Smith. You anticipated my my interest. The Medi-Cal expansion, I gather that you're speaking of is with respect to undocumented individuals who are up to that age range. Is that we're talking about the same
That is correct.
shift? Okay, thank you. Supervisor Ellenberg, the governor's office, who perhaps has an optimistic view of these things, has suggested that this might, the combination of these two things, the Medi-Cal expansion and the covered California premium subsidies, has the potential to increase coverage by as many as 1 million Californians. I don't have any way of knowing whether that's an accurate number, and I think what I might do is just ask our two experts here if they have any thoughts about that in a minute, a little ahead of their scheduled reports. But the reason I think it's an interesting number is that just coincidentally, Santa Clara County has 5% of the state population. We, of course, have our own population. It's different than the other parts of the state. But, what I always do when I hear a number that's statewide is say, all right, what's 5% of that? And, that would mean potentially 50,000 new people getting coverage here in the state. And this is, of course, an issue that, here in the county, forgive me. And this is an issue that I raised in the State of the County remarks that I thought was an important one, that if we could, as good a job as we have been able to do with federal and state support of getting folks covered, that there was still probably another 5 to 7% of the county that remained uncovered, and anything we could do to keep pushing on that, even though we know it gets harder and harder, was something I was hoping we can do. So my hope is that these actions at the state level give us some real opportunity to make even more progress, and that's why I appreciate Dr. Smith. I think we'll look on the committee agenda as to whether August or September works best, because I really would like you to feel like you have enough information about, do we know what the rules and regulations are going to be, how much of this is real, how much of it is just understandable optimism. But my hope would be that we could get tens of thousands more folks covered if the opportunity is there, and that's going to require a plan. That's going to require an expenditure of time, effort, and money to say, how do we reach this newly eligible population? Should we turn and say, what do you think? As long as we have you here, welcome.
Thank you. Kelly Brooks, I'm one of your legislative advocates.
Ms. Brooks, you are, but we can't hear your thinking unless we get the right buttons pushed.
Okay, let's try that again.
There you go.
Kelly Brooks, I'm one of your legislative advocates in Sacramento. I believe that the governor's office has been using data from the UC Berkeley Labor Center, and their estimates were, I think, widely regarded by folks. They use them to help estimate what the transition would look like in 2014 when the state expanded Medi-Cal. And I think that they have done some modeling around how different populations would behave and who's eligible and who may actually take up insurance and enroll in Medi-Cal. I think one of the variables that they were nervous about is whether or not the Trump administration's public charge rule comes out, and if that has some impact on, particularly on the undocumented expansion to Medi-Cal, if that has some impact on enrollment. But I think the numbers that folks are using, I think folks are fairly comfortable with.
Thanks. Thanks, Ms. Brooks. Mr. Margolin, nice to see you. Your thoughts, if any, on this particular subject?
Nothing really to add. I agree with the public charge comment that that's the major variable.
Okay. Dr. Smith, as I said, we will sort of think through just in terms of coordinating the agenda whether August, September looks like the right time. Obviously want to move as quickly as we can, but also, no point in having the conversation if we don't have the information we need to make thoughtful choices about how we proceed. Supervisor Ellenberg, thanks for your patience on this particular piece.
Sure, thank you. I'm going to shift direction, so I want to make sure you're okay on the Medi-Cal issues.
Yes, although we will be going through the rest of the
right.
A through whatever's.
Right, but I want to note that I'm appreciative of the summary reports that are now included from public health, custody health, and EMS. I think that's really helpful in balancing our focus across the whole HHS system. And I want to just make a quick comment about or question about the custody health report, not included in this report, but in the grievance reports from the sheriff's office. There's a disproportionate share of medical grievances from the female inmates, and I'd like to get some more information or analysis on what are the likely contributors to that difference, and how can we dig deeper. Is anyone from Custody Health here? Then perhaps we can translate that to an off-agenda question and request for report.
Thank you. Mr. Lorenz, anything else on A before we go to B?
No.
Thanks. Well, 7B is to receive the verbal report from our health officer.
Good morning, Sarah Cody, County Health Officer and Public Health Director. I just have a few items. Most of them are an operational update. First, I wanted to let the board know that the department has completed our next 3-year strategic plan. It's on our website if you're interested. It's pretty short and sweet. It's fairly inward-looking. It mostly is 5 priority areas to assist us in the how we do our work. It's not so much about any new initiatives. So please have a look, and we are happy to answer any questions you may have after that.
Thank you.
Second, I wanted to give an update on our CACHI project, the California Accountable Communities for Health Initiative. As you may recall, we were one of the 6 counties that were funded with the initial round of funding. That's the East San Jose Peace Partnership, a violence prevention project in 3 zip codes in East San Jose. We've just learned, so the 3-year funding cycle is ending this year. They're funding the projects again, but at a much lower level. So it will be an additional 2 years with $100,000 a year rather than the 3 years at $300,000. So we'll be able to continue, but in a somewhat scaled back fashion. Third, we, as you may or may not know, have had over the last several years a health system in public health for case management called FIZ. However, the program language is outdated. No one really uses it anymore. And so we've just completed the process of selecting a new vendor, Persimmon, and the kickoff for implementing the new information system in public health was this month. So we're now using Persimmon.
I'm just sitting here resisting any comment on the acronyms in your world.
That's all right. That's all right. So those are really the only updates that I had for you.
I do have one question, but I'm going to turn to Supervisor Ellenberg first.
Sure. Thank you, Dr. Cody, very much for this report. You noted in the report that prediabetes is a worsening trend, and that, of course, was reinforced by the Working Partnership report this month. Their recommendation really just focused on reducing sugary beverage consumption, but I'm wondering if you've got kind of a broader strategy and ways that public health is prioritizing prevention of obesity and diabetes, whether it's improving infrastructure, physical activity, what kind of things are we looking at beyond the soda piece?
Sure. Thank you for the question. This work happens in our Healthy Communities branch, and they've divided their work up into a few buckets. So one bucket is obesity prevention, and there's 2 parts to it. One is improving nutrition, and the other is increasing physical activity. Some of the work is very focused, and it's focused according to grant deliverables primarily, and some of it is population-based. So, for example, for promoting physical activity and active living, we have the Safe Routes to School program. We have the Parks Prescription Project, which is small, but hopefully can be scaled. There's the Traffic Safe Communities Network, which is in part, one goal is to get people out active, active transportation, get people out of their cars, et cetera. The nutrition project is part nutrition and part food security. And again, there's some parts that are very focused, that are grant driven, such as allowing people to use their SNAP at farmers markets. And others are more population based, including the the policy changes that we've had in the county to change, nutrition, what you can eat and drink at a county-funded function. Then there's also within the chronic disease, within healthy communities, the chronic disease work has some work that's focused on clinic to community connections. There's a large part of that work is the diabetes prevention initiative, some of which has been lifted through Transformation 2020 because we've been able to enhance our collaboration across the health and hospital system to think about how do we prevent diabetes from community level interventions all the way to what do we do within the hospital and clinic.
So you mentioned across the health and hospital system. I think, I don't remember if it was this meeting or a board meeting where we talked about integrated access to the data so that you can really track the outcomes of the public health programs. And I believe Paul mentioned that was complicated. Complicated doesn't mean undoable, and it feels to me extremely important for public health to be able to access de-identified data, patient data, so that they can really let us know if what they're doing is working. So how complicated, and are you getting together outside of these meetings to pursue that?
It is complicated, but the good news is that under whole person care, in the 2020 initiative that we have here with the health system, everyone is at the table and looking to aggregate the data to ensure that we can actually begin to use it in an effective manner.
Is that just for users of whole person care? That's a small population.
No, it is the total population relative to our database was HealthLink. So we're looking at aggregated data usage to identify patterns once they enter the healthcare delivery system. But that's, as you well know, is only part of the challenge we have from a community-wide perspective. But it does give insight into certain segments of the population.
What's the community-wide perspective that's challenging?
So Valley Medical Center, although we serve a large percentage of the patient population in Santa Clara County, it does not represent the total population of individuals that experience diabetes or related illnesses.
Sure, that's fair. So you can't get a complete look, but it would be broader, clearly, than what we have now.
It will give us a greater level of indication of what is going on in the community as individuals progress through the stages of the disease.
Okay. When that work is significantly further along and integrated, will you include that in a report when appropriate?
I think we can work with whole person care to give you an idea in terms of where we're at and where we're headed relative to the information.
That would be great. I appreciate that. Thank you. That's all.
Thank you.
Dr. Cody, here's a threshold question for you. So you're our public health official. What keeps you up at night? I'm not asking you to scare everybody in the chambers. I'm just asking you. One of the great challenges of the county and even within individual departments and agencies is the breadth of the work we do. I mean, so on any given day, if you're a county supervisor, you could be thinking about a potential public health threat, but you might also be thinking about the animal shelter in South County or Reed Hillview Airport or even Stanford land use, depending on your, for example. So as I was listening to your report earlier, I thought, we've had some public health traumas over the years. I'm just curious, what's keeping you up at night these days?
I think what keeps me up at night is what you might guess is that there's a tremendous breadth in the public health work. And so I am responsible for both keeping the team in infectious disease and response excellent, because we never know what's going to happen. And if we don't execute close to perfectly, we will feel that for a long, long, long time. So we both need expertise and people who can work with our Office of Emergency Management and EMS and everyone else to respond quickly to whatever the public health threat might be. And at the other end of the spectrum, we need people who can, plan on a 10 to 20 year horizon to think about prevention of chronic disease and think about all of the social and environmental factors that underlie poor health outcomes and drive the majority of the morbidity and mortality. And that's a different skill set and a different way of thinking and a different type of planning. And then we need everyone in between.
Got it. I'll say thank you. That's helpful, actually, in terms of thinking about the range of responsibilities in your organization. And then before we go on to 7C, and I don't know if that's a separate report from Mr. Lorenz, I will just say, staying on the report from the health officer, because one of the benefits of these meetings is that we share information between and among various folks. Dr. Smith, you will recall, I in response to, I believe it's Supervisor Ellenberg's referral on the uptick in syphilis, which is a source of concern, I've indicated I'd like us to take a look at the same time at the wider range of STDs, STIs, and see whether or not some of the approaches that Supervisor Ellenberg is anxious to explore might not have broader, wider applicability. So I just want to make sure everybody knew that that was in the conversational mix right now, because we've got some troubling data with respect to other STDs, STIs besides syphilis. Okay. All right, thank you. That takes us to 7C, Valley Medical Center. Mr. Lorenz, further report?
Thank you, Supervisor. Outside of the written report, I have nothing to comment on at this time. I'm happy to answer any questions that you may have.
And thank you. I think we've covered a lot of your territory in prior conversations today, so thank you for that.
Thank you.
That takes us to 7D, which is to receive the report from the Director of the Behavioral Health Services Department. Ms. Tullies, I see you leaning in.
I'm leaning in. I just want to highlight a couple of things in the report, and that is that we've had our go live for NetSmart, a series of meetings, and those are ongoing. I think it's very exciting for our department because we haven't had the kind of data available to meet the needs now of all the new requirements. So it's very exciting. We'll be bringing all of the contract providers on in the next month or 6 weeks. They'll be part of a work group as well. So it took us quite some time to get here, but NetSmart has been extraordinarily responsive, and our staff at every level are very enthusiastic because they feel that the vendor understands our field and what our needs are. So it's good.
Thank you. Supervisor Ellenberg, and then I've got a question or two.
Thank you. I know we have a more robust discussion of behavioral health services scheduled for August.
Yes.
So at this time, what I'd like to do is just make 3 requests for things that I'd like to see in that report. The first is a status review of all of the new services that are being implemented in the community, particularly for homeless, justice-involved, and high-needs populations. Second, a review of the first several months of the mobile crisis response teams, looking at call volume, types of calls, outcomes, operational issues, and community outreach. And third, I think this would be a good time to revisit the discussion of AOT. I think the last time HHC addressed this topic was about 2 years ago, but particularly in the context of some of the programs that are being launched now, I would really welcome a robust conversation on that topic and try to develop a deeper understanding there. Thank you.
Fine. And I know that Supervisor Ellenberg, you were asking about the contracts, and they're giving me daily updates. But we've had a lot of movement since this report. So right now we have about 58% of them with the providers, and the remaining are in signatory process, and some are already completed.
Thank you, and we've been tracking that outside of the meetings as well, and I really appreciate that effort, and I'm certain that the Behavioral Health Consortium appreciates that as well. Thanks.
Thank you. Ms. Tully, no surprise, I'm going to ask you about Headspace in San Jose and in the North County. How's that going?
How's that going?
Yeah.
Well, we've been sitting here today. Dr. Adelsheim is sending me quite a few texts about our next steps. We have a meeting that's taking place while we're here at HHC, and we are launching with a project manager the implementation plan for Headspace. It'll be very similar in both of the sites. We'll have different staff working with Stanford and Palo Alto, and then county staff and contract agency staff in San Jose. We have identified the areas that we need to focus on right away, and that has to do with consent and also just how we organize the actual delivery system there. So I would say it's good. It'll be a very good team, and we have a dedicated project manager to lead this. So I'll be very involved, as will Dr. Adelsheim and our respective teams, but I want somebody to project manage to make sure we stay on task.
Thanks. If I were, a day that the doors will open in San Jose, target date is what?
Well, I know that the lease for San Jose is coming to the board in August. My understanding is in order to create the appropriate space with the design could be up to 6 months. The lease hasn't come forward yet. There's lots of conversations going on. The design of the centers is really based on the very innovative work that occurred in both Australia and British Columbia, and our youth advisory groups have been the ones to focus on the design. So, it could be shorter, but I don't know. That's not, I can't give you any more information than that.
Palo Alto?
I think Palo Alto would probably be similar.
Okay.
And I'm going to see that site very soon. So we'll have a better sense as well on that one once we get into the site and really look at what's necessary.
Thank you.
For design.
And Supervisor Ellenberg, full disclosure on the Palo Alto site, I've been, I think to say hands-on would be to understate the case, Ms. Tully's, and but with help from County Counsel's office, facilities and fleet, and behavioral health, just so that we can ensure that there isn't any slippage, that things are done simultaneously rather than sequentially where possible. And I appreciate the efforts of all three departments, agencies, offices to make that happen. And then, Ms. Tully, if I could ask, you came to the county when?
January of 2015.
So, Supervisor Ellenberg, you've heard a conversation before about the teen bed building as I describe it. Those conversations got started in 2015. By the end of the year, we had, I think, clarity about the fact that there clearly was a need and that such beds would be filled. By the end of 2016, we had tried to use the conventional RFP process and come up short. By the end of the 2017, we had ascertained that if we could find a more collaborative process, we could engage community partners and other institutions, including Lucille Packard Children's Hospital at Stanford and El Camino and Kaiser. And then in 2018 and 2019, our board has repeatedly expressed its support by formal action here in the board chambers for a facility on the VMC campus that would meet the acute care needs for psychiatric care here in our county, so that we weren't shipping kids out of the county. And while that's taking more time than we would all like, we're on track. Mm-hmm. Yes, Ms. Tully's and Dr. Smith, and thank you to all parties. Yeah, okay. Yes. And I'm just surfacing it again because I want people to sort of know where we are in this exercise. Ms. Tully, I should just say for the record that as we had the conversation about teen beds and a secure acute care facility, other mental health needs, including with the adult population, were identified, but also for youngsters who had other medical needs as well. And so when I say teen beds as shorthand, and because that was my initial focus, I don't want that to be misunderstood as not including these other things. Okay. Dr. Smith and then Ms. Ellenberg, if you'd like, on this topic. Yes.
Just before you get finished with 7, please don't close the meeting. We have one correction to make after we're done with this item.
All right. So, Ms. Ellenberg.
I actually want to make a correction to the record right now. And Mr. Lawrence, my office did receive the off-agenda report, so I don't want to cast any aspersions. It had gotten to my office, but not to me. So thank you very much for producing it, and I will read it this afternoon.
Got it. Anything else on behavioral health?
I would like to just notice you that the work that we're doing with what we are now calling in California alcove has become a there's a lot of visibility of that effort. And I'm at the state level. There are many, many conversations about this work and how it could be utilized across the state. And in addition to the design and the services and the prevention, we included here in Santa Clara County, with your support and Dr. Smith's support, the opportunity to look at, could we contract with a commercial plan to try to let all kids receive these services? And there's quite a bit of interest and support with leadership at the state level. And there'll be more to come, but I think there's a lot of opportunity for Santa Clara in the coming year, a lot.
Thank you. That takes us to item 7E, which is to receive the report from the CEO at the Valley Health Plan.
Thank you, President Simidian and Supervisor Ellenberg. I do have one item of update I'd like to cover in addition to the contents of the monthly report, and that is that Valley Health Plan is going through a change in leadership at this time. Due to a variety of family and lifestyle factors, I have made a decision to make a career transition and will be assuming a similar role in a health plan in the Pacific Northwest. Dr. Smith and I have been working extensively on transition planning, and I'm very pleased to announce a key component of that today, which is that Deborah Halliday, Valley Health Plan's Chief Operations Officer, has agreed to become the interim CEO of Valley Health Plan, and Deborah is in the front row over there, so if she could give a wave. Deborah is very strongly qualified in my view for this role. I would expect absolutely no deceleration of progress for Valley Health Plan, and quite probably the opposite of deceleration, but certainly a very orderly transition. And then going forward, Dr. Smith will be conducting the search for the permanent CEO. But just in closing, I would like to express very heartfelt thanks to the Board of Supervisors and to county leadership for their strong support and advocacy for Valley Health Plan's success over the past several years, and for allowing me the opportunity to lead VHP on this leg of its journey. And also a heartfelt thank you to all my colleagues in the county and the community, and even a few people in Sacramento for making this fun and productive and a gratifying experience. So with that, I'll entertain any questions that the committee might have.
Well, it seems to me if this is your final meeting, that my gift to you is no questions today. But
thank you very much,
I
President
do.
Simidian.
I do want to say thank you, and I do want to wish you well in your new endeavor. And I do want to call out for those who have not had occasion to follow your work or the work of the Valley Health Plan over the last several years. This has been a time of extraordinary transition as well as growth. It's just a challenging time. There's no other way to put it. So when I say thank you, it's not just a perfunctory thank you. It's a thank you for your work during that very challenging time. And the last thing I will say, and your transition just offers the opportunity to say it, is I think one of the challenges that many people in the room face, and certainly you, is that the work's never done. You don't get to say, that's it, that's a wrap, we're done, we're out of here, it's all good. Because when you wake up tomorrow, there's going to be more of the same and some new challenges as well. And I think we sometimes understand that for our nurses and our docs and the other practitioners, but I'm not sure we always understand or acknowledge that for other people. I mean, there's a reason there hasn't been a hospital show called Hospital Administrator. I mean, it's just, you know, sorry, Mr. Lorenz, but you're,
there should be.
Well, there you go. And the same, you know, with VHP, you know, every day you walk out the door, you've affected thousands of people's lives. And I just think we should take a moment to recognize that and say thank you. And Supervisor Ellenberg, Dr. Smith is leaning in as well, but after we hear from you, I'll go to him.
I would just echo my colleagues' comments and wish you the very, very best in your next endeavor.
Dr. Smith.
Yes, I wanted to just publicly thank Bruce very much. He's been a great leader during this difficult time, as the chair points out. I've had a lot of pleasure working with you, Bruce, and you know, you've set a good stage to leave at this point as good as it can be in the terms of, you know, still questions ahead. And I think Deborah is a great person to take over the reins, and I look forward to working with her. I can assure everyone that Valley Health Plan is healthy and moving forward. Deborah will continue to report directly to the county executive as partners with the rest of the health system. But we plan expansion, and I'm quite confident that that will happen. So thank you very much. And again, sorry I won't be able to make it to your event tonight. I have a prior family arrangement, but somebody will have a glass of wine for me.
Thank you very much.
Thank you.
And thank you, Dr. Smith, for the reminder that the wine is medicinal. So that's an appropriate one. All right, that takes us on to our next item, which is 7F. And while the report or the agenda indicates that the report will be relating to federal health policy and budget landscape, we're going to incorporate state as well because of the activity at that level as well. So, Mr. Margolis and Ms. Brooks, who'd like to begin?
I think I'll start with the federal, if that's all right, Mr.
Please.
Chairman, and then we'll move to Kelly for the state. I have a relatively brief report this month. There have been few significant developments since I was with you end of last month, but there have been some developments. So starting with pharmaceutical, the effort to get a federal reform on pharmaceutical pricing. We've talked before about how there's broad bipartisan consensus on generic drugs being advanced to the marketplace. Figuring out how to deal with pricing has been more challenging, and Speaker Pelosi has been engaged in an internal negotiation with her own caucus on the question of how to do drug pricing. She put forward a proposal last month that involved subjecting the 25 most expensive drugs to an arbitration process. The Progressive Caucus pushed back on that proposal as being too limited, and they're moving towards agreement on what appears to be a 250 drug list, a much larger list of drugs, but the Pelosi principle here of arbitration still being the main mechanism. They have no final agreement yet, and obviously, even if the Democrats in the House agree amongst themselves on how to deal with this issue, you've got the Senate and the administration to deal with, but just wanted to update you on that issue. The other issue that's occupied a lot of time in Washington is the question of surprise billing, the situation where you're in an ER and an out-of-network provider bills you an astounding amount of money and you are unprepared for that as a patient. The state of California, as Kelly well knows, dealt with this issue with Assemblymember Bonta's legislation in 2016. And the Senate right now and the House are dealing with solutions that are actually very similar to what California has already enacted. The Senate Help Committee, chaired by Senator Alexander of Tennessee, along with his Democratic counterpart, Senator Murray, earlier this week began marking up a bill that represents a bipartisan compromise, a mechanism for setting prices for out-of-network costs that's very similar to what California, again, has already done. This may be one of the few bipartisan agreements this year because on the Senate side, in particular, Alexander and Murray are working together on this issue. Insurers are okay with this solution. Providers are not especially happy with the approach that's being advanced, but again, there's much more negotiating to do down the road. On the pre-existing condition front, the Texas lawsuit issue, House Democrats last week put an amendment into one of their appropriations packages, which was designed to highlight the issue of the Texas litigation by barring the use of any federal funds to advance the Trump administration's position in support of that Texas litigation. That language is unlikely to survive the full process. In fact, it's almost certain not to. But what the House Democrats wanted to do is to have an up or down recorded vote on where you are on the Texas litigation, which would repeal the Affordable Care Act and in particular targets pre-existing conditions. So it's a way of putting that issue out there. Speaking of that litigation in the Supreme Court, when I arrived in the board chamber this morning, Dr. Smith approached me to tell me about a Supreme Court decision that came down this morning, which I was on an airplane, was unaware of until he advanced the issue and briefed me on it. The census, the citizenship census question that we've all been following because it would have such a negative and dramatic impact on states like California. Apparently, the Supreme Court this morning rejected the Trump administration position, remanded the issue back down to a lower court with Chief Justice Roberts siding with the four more liberal members of the court, the five of them on a 5-4 decision, essentially saying, as Roberts put it, that the administration arguments were contrived. That's a direct quote, and not compelling, not persuasive. And they had to find a better argument for a citizenship question than the one that they advanced. He found it, again, to be contrived. Again, that 5-4 vote may be a preview of what will happen when the Texas litigation reaches the court. We don't know for sure, but it's interesting that Chief Justice Roberts went against the Trump administration on this question and took the position that he did.
Excuse the interruption, and I'm here. The notion that it might be indicative of a 5-4 alignment on the Texas case is that a function of some similarity in the issues or the debate, or just a function of the assessment that Justice Roberts is showing his willingness to break ranks?
It's a combination of the two to some extent. He definitely is showing a willingness with his decision to break ranks and tell the Trump administration somewhat forcefully, you're wrong, your arguments are wrong, and that's worth noting. There's also some, that we're dealing again with access to healthcare services, access to social services. There's some overlap in that regard. And again, many people believe that the Texas lawsuit is on pretty thin ice in terms of the logic that's being used. And again, Justice Roberts is taking this census issue and directly challenging the logic as well. So some substance and some just indication here of a willingness to challenge the administration.
Thank you. Please continue. I just wanted to make sure I didn't lose that.
No, certainly happy to clarify. There's also been an action this week by the president when he issued an executive order on price transparency in how hospitals disclose their pricing to patients. The administration attempted on Monday to make this price transparency announcement appear to be a very significant announcement with major implications for patients, and it may at some point down the road have significance, but it's important to note the executive order was really an instruction to Health and Human Services to draft a reg. So it's sort of an introduction of the issue. It's saying work on this issue. It isn't really a final product. So we'll see how that plays out over time. Another issue that's playing out on the administrative side is the effort by the Office of Management and Budget to change the inflation factor used to calculate the federal poverty limit. That's massively important for states like California and others around the country because it will affect over time the eligibility for Medicaid and all sorts of other social programs, social service programs. OMB asked for comment on alternatives to the current inflation factor. They didn't propose specifically which factor they're going to embrace, but they asked for comment. Comment period just ended on June 21st. Sometime in the months to come, they'll come out with a proposal or an action that will implement a new methodology. And again, there's likely to be litigation following that and won't be an easily resolved issue, but it's one that we need to all track because it has major implications for eligibility for these programs. One other item, two other items to touch on, then I'll be finished and happy to turn it over to Kelly. The news media has reported on a split, which is sort of unusual in the Trump administration, between White House officials and Secretary Azar in the Health and Human Services Agency, and a certain level of tension over decision-making. Again, until recently, there's been a fair amount of agreement between the White House and Health and Human Services. Apparently, this tension, this area of disagreement, has festered for several months over issues like the Texas litigation, where the Trump administration, end of last year, changed its position and decided to weigh in fully for repeal of the ACA. Secretary Azar apparently internally thought that was a mistake. There was also a recent decision by the administration to ban the use of fetal tissue in NIH research. Secretary Azar apparently questioned that, but he lost in that internal battle. The administration has worked pretty hard the last couple of days to deny there's any schism, any split, but the press reporting is pretty compelling that there has been this difference of opinion, and again, that will play out in the months to come and worth our noting. And the last item in my report involves Title 10, the family planning funding issue, where the administration is attempting through its new regulation to limit access to abortion services and abortion counseling. There's been a lot of litigation on this issue, and until recently we had a stay in the implementation of this regulation while the case was being litigated. Several judges around the country said this can't be implemented while it's being litigated. Quite surprisingly, a 3-judge panel in the Ninth Circuit last week said, in fact, the opposite. They struck down all the stays nationally and said this needs to move ahead and be implemented while it's being litigated. Planned Parenthood, ACLU, and others have filed an emergency petition with the Ninth Circuit to reverse last week's decision. And even if it isn't reversed, there's no way you can take this grant program and on a dime change the way it's structured. They'd have to go out with another RFP. There'd be some delay in changing course, but it's worth noting the Ninth Circuit decision and worth noting that this issue is once again in play. And that completes my report.
Thank you. Ms. Brooks?
Good morning. So the legislature passed the spending plan 2 weeks ago today. It's a $150 billion plan for 1920. The governor's main investments, or the areas where he's spending more money than his predecessor, are in the areas of education and healthcare. He's made very clear his priority around early childhood education, and he's been very proactive on healthcare issues as well. He issued a lengthy executive order on healthcare matters his first day in office. The budget itself has not been signed by the governor yet. What trails behind the budget are a number of things that we call trailer bills, which are legislation that provides the statutory framework for the different items that are being expended in the budget. There are a few items that they have still been negotiating on, and I actually just got an email with some more detail. So the two big items that we're hanging out are around housing and homelessness and around access to clean drinking water. Apparently they've reached an agreement, it's been reported in the press as well, around housing and around homelessness. On the housing side, the budget provides $1.75 billion for housing production. And the governor was very concerned that there weren't enough incentives, particularly for cities, to build affordable housing. And so they've introduced the idea that courts would play a new role in violations in local jurisdictions that are not building enough affordable housing. So we'll have to see what the language actually looks like, but it sounds like the state will have another tool in trying to enforce what local governments are doing to build affordable housing. And then there was some open question around how the homelessness money was going to be distributed between cities, counties, and continuums of care. The agreement is that $175 million will be directly allocated to counties, $275 million will be allocated to the big 13 cities, and then $190 million will be allocated to continuum of care reform. There are other pots of funding in the budget around homelessness, and if you add all of it up, it's $1 billion in state expenditures toward homelessness issues. I thought I would talk a little bit more in detail around healthcare, the investments in healthcare, and I think the way I'm going to frame it is the governor has ongoing investments in healthcare, and the biggest one is around expanding Medi-Cal for undocumented adults. There are a lot of new investments in healthcare, but many of them are time limited. I think the governor has been very concerned about, is there another recession coming, and how do we prepare for that? The budget includes $19.4 billion in reserves between the mandated rainy day reserve, and then the legislature last year created a safety net reserve. This is significant and unprecedented. So the approach that the administration took in negotiating with the legislature, who of course wanted to spend more money than what the governor had proposed in his budget, was to implement programs and then have a review of state revenues in December of 2021 to see whether revenues continue to be on track, and if they aren't, some of these programs will go away or no longer be funded. And so that was the approach they took. I just would call out, so on the governor's big initiatives in healthcare, you have the expansion of Medi-Cal to undocumented adults. You have the affordability proposal that Mr. Lorenz talked about. The legislature was able to get the governor to invest more money into making insurance more affordable. So he had proposed solely using the revenues that come from the individual mandate penalty that California is newly enacting. The legislature got him to invest an additional $450 million in general fund for the purposes of subsidizing premiums, which is significant because I think it really better addresses the questions around affordability and want to allow people to purchase insurance. One of the areas where the legislature had some consternation is that the governor had proposed just letting something called the managed care organization tax expire. So in California, and other states do it too, they impose a tax on managed care plans, and that revenue is used to offset general fund spending on Medi-Cal. I think the legislature was concerned about letting $1.5 billion expire and not making an effort to negotiate with the federal government. So there is language that says that the administration will go forward with trying to obtain another managed care organization tax, but there's no revenues spent in the budget, and it's sort of all contingent upon federal approval. I think there was some concern with the new administration about how a negotiation with the Trump administration would play out given the sort of larger California versus Trump issues.
Ms. Brooks, excuse the interruption. I'm just trying to go back into the recesses of my mind.
Yes.
The Medicare, excuse me, the managed care tax, as I recall, was actually supported by folks in the managed care
Correct.
industry because they saw that as the vehicle by which they could be the recipients of
Rate increases.
Great increases, yes.
Exactly.
Okay, just thank you.
Last time around, to sweeten the deal, because the tax applies broadly, not just to Medi-Cal managed care plans, they did some things in the tax code to give a tax break to some of the commercial plans that don't have a large book of business in Medi-Cal. So there were some trade-offs that were beneficial to the plans, and they've supported it in the past. And I think folks are hoping that they can negotiate a deal on this going forward. The legislature was also successful in restoring optional benefits to the Medicaid population. So several optional benefits were eliminated during the Great Recession, and they've gotten all but chiropractic restored through previous years and through this budget this year. And that was a priority of the Senate Budget Chair. I think you all have been very interested in what's going on with the governor's executive order around pharmacy. He has proposed to transition the pharmacy benefit out of Medi-Cal managed care into Medi-Cal fee-for-service. The budget trailer bill language includes a formal process to have stakeholder input about how that transition is going to roll out. And so I think this is an opportunity for folks to be at the table and talk about some of the impacts, particularly to public hospital systems and to federally qualified health centers who get a benefit from the 340B program and the way they've structured the proposal. There's definitely some impact to those entities. And so we will see probably over the next 18 months that process play out. The thought is that that transition would happen January 1, 2021. But it's a pretty long road between now and then of all the sorts of things that have to be put in place from a state infrastructure perspective. So I think there's sort of more to come on that, and I think we will see further conversation, particularly over this fall, on that issue. On the another really interesting discussion that occurred via the budget process this year is around something that was put in place last year that was championed on the Assembly side, and it was a healthcare council that was going to look at cost and transparency and think about how to move toward more universal health care and look at sort of the financing infrastructure. The governor proposed renaming the commission to the Healthy California, or calling it a commission, not a council, renaming it the Healthy California for All Commission, and having it have a more single payer focus. The speaker whose house had championed the proposal from last year and who has had some political issues with the California Nurses Association, who's the main champion of single payer, pushed back, and this was something that was negotiated up until I think late last week. And so they reached a compromise. It's getting renamed the way the governor wants. They're adding more members, so it's a bigger body. And it will still look at single payer, but it will also look at other ways to achieve universal health care. So this is clearly a political issue. And then I would also mention, because of the conversation you all have had this morning, there's significant one-time investments in public health. There's $40 million for local health departments, for infectious disease control, and then there's $5 million for each for STD prevention, HIV prevention, and hepatitis C prevention. I think this administration was much more interested in public health issues than we've seen in the past. And so it'll be sort of interesting to see as we move along sort of the level of interest that continues. But I think they felt like this was an area where they wanted to see some investment because of the really serious issues that have been going on statewide with infectious disease.
Thank you very much. Lots of ground. Much appreciated. Comments or questions? Oddly enough, I'd like to go back to the housing piece, since we've got the opportunity, and not that anyone's asked lately, but since I have the opportunity to just send a thought back with you. Not surprisingly, all of us are hearing a lot from our constituents and locally elected officials in the cities and towns we represent about the debate on housing and SB 50, Senator Wiener's bill in particular. And housing advocates are saying, hey, something's got to be done. Opponents to the legislation are saying it's heavy-handed, one size fits all. I'm going to put all that on the side for a minute and just say, understanding the prior governor and this governor's reticence to spend budget surpluses during robust times on ongoing commitments, which may not be manageable in subsequent years, it does seem to me that there is a unique opportunity while we're having the housing conversation to provide some one-time funding in the way of carrots rather than rely solely on sticks. I don't know what the number is, and I don't know how it would be put to best use, but whether it's $500 million, $1 billion, $2 billion, $5 billion, $10 billion, the benefit of a one-time expenditure in that area is that it would have lasting benefits in terms of ameliorating the housing shortage and cost challenges that we're facing today. And I keep waiting for someone, because it's been a 2 or 3 year conversation now, to lean in a little more aggressively and say, the way to make this palatable is to put some one-time only funding on the table in a significant and meaningful amount as a way to ameliorate the concern about all sticks and no carrots. So
I think the governor may have heard you. There is funding in the budget that is meant to be carrots for local government who meet their affordable housing goals. And it's my understanding is the money is meant to be flexible, and so local government will get the money and then they can spend it however they see fit. So if it's infrastructure improvements that are necessary related to the housing or whatever their local needs are. And I'm going to be honest, I thought the number was around 500 million, but I will go back and double check what actually made it into the final agreement. But that was on the table for discussion.
I'm taking us a little far afield here for the Health and Hospital Committee, but since we have you, I want to take advantage of the opportunity. The dollar amounts really do matter here, and the ability to have some meaningful impact. I'm sure our county will look at the dollars that you've described and assess whether or not there's some opportunity for us there. But I think, years ago we used to talk about the fiscalization of land use. That term has somehow fallen out of favor. And in fact, I read a study a few years ago from the Legislative Analyst's Office, and I think they do very good work, but I think they were off the mark uncharacteristically on this. They sort of said, no, that's not a real thing. Well, here's what I know. I know that locally elected officials make judgments that they think are in the best interest of their local community, and they have been approving development, so they're not anti-development, but they haven't been approving housing. And I think they've been doing that because they think that development approvals are in the interest of their local community in terms of job creation and tax revenues and limited demand for services, and they think that housing creation is not. So if it's all about the money, then somebody needs to step up and say it's all about the money. And I know you don't have 120 votes in your pocket, but I just wanted to send that message back with you, because I think we're sort of forgetting that people make decisions that they think are in the self-interest of their community, even though it doesn't work to the long-term benefit of the wider region. Supervisor Ellenberg, any reason we shouldn't move to receive all of the reports under item 7?
No reason whatsoever. So.
All right, I'm going to call that a motion to receive the reports, and the report singular with its many parts and without objection. So ordered, and we'll thank you both. And then before I move on, Dr. Smith, you had asked if we could please make sure we corrected an error earlier.
Yes, Mr. President, there's some concern about the action taken regarding number 4, and I'll turn it over to County Counsel Doug Press to read some language to make sure that the committee actually approved the medical staff recommendations.
Okay. Mr. Press?
Yes, this is just to make the record unmistakably clear. I thought I heard you say approve, but just to make sure that the notice in the ledge file and your actions conform, we just want to add that item 4 includes the recommendation to approve appointments and reappointments and privileging actions of specified enterprise medical staff and allied health professionals at Santa Clara Valley Medical Center, O'Connor Hospital, and St. Louis Regional Hospital for the month of May 2019.
And without objection, hearing none, and with unanimous consent of the committee, which is Supervisor Ellenberg and myself, we will indicate for the record that the action taken on item number 4 incorporates that language and direction. Supervisor Ellenberg, is that agreeable to you for the record?
It is.
It is. All right, then I think that takes us to a motion to adjourn. Motion by Ellenberg, second by Simidian. Thank you all. Enjoy your summer. We are adjourned.